Well, hello, everybody, and good afternoon or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I am the managing editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by DataLink. And it is titled the Medicare Advantage HEDIS and Star Measures Review. This is a really hot topic. I know a lot of you are very interested in hearing what we have to say today, or what our speakers rather have to say today. And I've had a little sneak preview of the presentation, and it is fantastic. So I think you're really going to enjoy it. A few items of note before we get started. Everyone has joined today in listen-only mode, so this is a traditional webinar format. We can't see you or hear you, so don't worry about turning off your camera or your microphone. However, we do want to hear from you, and we're going to have a time for some Q&A towards the end where we can answer your questions. So if you have a question for either of our speakers or just in general at any point during the presentation, go ahead and drop your question into there's a module that you have as an attendee specifically for questions, which is different than the chat. So just go ahead and put your question in there. We're going to get to as many as we can during the allotted time. If we don't get to yours for some reason, don't worry. Someone will reach out via email afterwards, make sure we answer your question. So let's see, what else? We got today's session is being recorded. And what's going to happen is afterwards, when we're done, about within an hour or so, hopefully, you'll receive an email from one of us, and there'll be a link to the recording. As well as to where you can download the slides. And I know there's a lot on the slides today, so you'll want to make sure that you do that. And so we'll get that to you just after we conclude. And without further ado, I'd like to introduce our speakers for today. So we have, first of all, we have Ms. Kelly Kolob. She's the Director of Value-Based Care with DataLink. We also have Yasti Puig, and she's the Value-Based Care Education Leader with DataLink. So I'm going to turn it over to y'all at this time. So welcome.
Thanks, Garrett, and welcome to everyone joining us today. We're really excited to be here. Yasti and I both worked in provider spaces in past roles, and we know the challenges that practices have understanding quality measures and incorporating them into your workflows. At DataLink, we're part of a team that works with providers every day to help them succeed in these areas. So I'm going to start things off today by giving you a brief introduction into the Star Ratings program, but then Yasti is going to give you a detailed review of the Medicare Advantage, HEDIS, and Part D measures. And we will discuss strategies to enhance documentation, tips and tricks to optimize your workflow, and we will provide resources that support your quality initiatives. And just a disclosure, the webinar today is for informational purposes only. It doesn't replace medical advice from medical professionals. Today's discussion follows NCQA HEDIS and CMS STAR guidelines, but please review the requirements in your specific Medicare Advantage contract because sometimes those measures vary. All right, well, let's start with talking about what Medicare Part C and D-Star ratings are. So it's a program that's administered by Center for Medicare and Medicaid Services, or CMS, and it rates the performance of Medicare Advantage and Part D drug plans that are offered by private insurance companies. Now, over half of all eligible Medicare beneficiaries are now enrolled in these plans, so it provides information to those beneficiaries and new beneficiaries who are making enrollment and coverage decisions. Ratings are released every year in October prior to Medicare open enrollment, and they're posted on CMS's website and Medicare.gov. Now, health plans are rated on a scale of 1 to 5, with 1 being poor and 5 being excellent. All right. We're currently in the performance year for the 2026 STAR ratings, so specifically for the measures that we're going to cover today. So the work that you're doing this year impacts the health plan STAR ratings in 2026. The 2026 STAR ratings have up to 45 measures, 33 are Part C and 12 Part D, and each measure is assigned a weight between 1 and 5, which allows CMS to assign heavier importance to some measures when calculating STAR ratings. There are also several measures that are display only, and those measures have no weight and they don't impact the STAR ratings, but sometimes they become weighted measures in future STAR years. So as you can see on the right, there are many data sources for these measures. These sources include consumer surveys, quality measures, complaints, and improvement metrics. Today, our focus will be the weighted HEDIS, SUPD, and medication adherence measures. HEDIS measures are developed and maintained by the National Committee for Quality Assurance, and the SUPD and medication adherence measures were developed and are maintained by the Pharmacy Quality Alliance. Okay, so I'm not going to spend a lot of time on the next few slides, but I wanted to briefly show you all the measures that make up Part C and D star ratings. These are the 2026 Part C star measures, and I've highlighted the measures that we will review today. You can see the weights given to each measure on the right, and as you can see, we are going to review some of the higher weighted measures. We'll go to the next slide. And this is a continuation of the Part C measures, and then the next. And this is the 2026 Part D star measures. So you will note that there are 3 highly weighted measures that we will cover today, those medication adherence measures. So I know that this was really quick. Just remember that these will be in your slide deck, and there is also going to be a link to the information on the resources slide. Okay, so before we dive into the measures, we wanted to briefly talk about the why behind star ratings for patients, providers, and health plans. So why are star ratings important to patients? Well, as I mentioned, star ratings provide quality and performance information to Medicare beneficiaries making enrollment decisions. Here you see an example of what an individual might see when they visit the Medicare.gov website to review health plan options. In the middle of the screen, you will see the star ratings filter, and it's outlined there in red. Individuals who are searching for plans can filter to higher rated plans, and then they can consider those results along with plan benefits and premium cost and other items that are on this site. So it just helps them to make a more informed decision. And why are star ratings important to providers? Star ratings may impact a provider's ability to receive incentive or shared saving payments through their Medicare Advantage payer-provider contracts, but it is not that straightforward. So let's take a deeper look into how this works. Starting from the bottom of the chart, you can see how individual providers' performance is aggregated up into the performance of the provider groups and then up into the health plan star rating. CMS is not measuring individual providers or provider groups through the star rating program. CMS is rating the health plan. But as you can see, provider performance impacts star ratings. So most MA payer provider contracts incorporate star measures into the contracts, and providers receive a star-like score. That is the score that may impact whether or not providers receive additional payments through their MA contracts. So you're going to see an example of a provider group star score later in this presentation. Different from CMS's star ratings program, star scores that are received through payer-provider contracts are usually based on the current year performance. And why are star ratings important to health plans? Well, as you saw earlier, star scores have the potential to have a great impact on Medicare consumer decisions. They also impact the health plan's ability to receive quality bonus payments and the rebate percentage that they receive from CMS, which helps them fund additional benefits like vision, dental, and transportation. And it also makes the plan more appealing to enrollees. High-performing plans are allowed to enroll Medicare participants all year long through the special enrollment period versus just a few months during open enrollment. And this allows plans the potential to grow their MA membership. And low star performing plans may lead to their contract being terminated by CMS. All right, so it's time to pass this over to Yassi, who's the real star of the show. She's going to review the measures with you. Take it away, Yassi.
All right. Thank you, Kelly. All right, I got to tell you, educating on star measures is one of my favorite things to do because back in 2012, after working 10 years at a gastro's office, I decided to take a job at a PCP's office. My very first day on the job, the doctor walks in with somebody from the MSO who handed me all of these reports and said, she's going to be your contact person for all the HEDIS stuff. I had no idea what he was talking about. I was completely overwhelmed and I had no clue where to even go find this information. So today, I hope to explain them to you how I wish someone would have done for me 12 years ago. So let's start with a few terms that you're going to hear me mention throughout the presentation. The first one's going to be measurement year, and this is basically the time period when services are actually provided. Then you have patient reported. This is data or feedback provided directly by the patient to their healthcare provider and documented in the medical record. And then you have supplemental data. This is additional information which could be used, and it could include things like the patient reported information. And this is usually stuff that have not been captured through a claim. Then you have the CPT-2 codes. These are used for reporting quality data, often made up of 4 numbers and a letter. They are very different than CPT codes, though, which are usually used to bill services provided. The CPT-2 codes are mostly used for like administrative purposes. And lastly, thresholds. These are usually set as a percentage of your numerator and denominator, which will determine the star level. Each measure will have different thresholds, usually estimated by the payer for that measurement year, but then the final thresholds are set by CMS. All right, so let's look at the components of each measure. I will start by giving you that breakdown. There's 4 basic parts for each measure. So besides their names and the weights that Kelly has already mentioned, each measure will have details and rules set by each of those governing agencies. As Kelly said, for HEDIS is your NCQA, and for your pharmacy measures, it's going to be PQA. Now, these rules are released in their technical specification manuals every year. So we have taken that information and kind of clumped it up for you and giving you the most important things that you need to know. Okay. So the first part of every measure is going to be the eligibility. This will tell you who and why someone will qualify for a measure. This could be based on things like their gender, their age, an event, a condition, a medication, etc. This is what puts the patient on the denominator. Then you have requirements, which outlines what needs to be done in order to close the gap in care, which will then add the patient to the numerator. So for each measure, it is important that you know what needs to be done, how often does it need to be done, and whether the results matter or not. Then you have a third part. Those are exclusions. These are reasons why a patient might be removed from the eligibility, which basically removes them from the numerator altogether. And lastly, you've got submissions. If the patient is in fact compliant, or if they need to be excluded from the measure, you will need to know what documentation is required and how would you then report it back to the payer. Now, some of you might be very lucky to get really good reports from your MSO or your payers, but really understanding the basics will help you close these gaps in care, even in the absence of good reporting. And I know many times at the beginning of the measurement year, we don't get all of the eligibility and all of that from the payers until like April or May sometimes. So I want to quickly show you how this information that I just reviewed on the previous slide will look for you on a report. What you're seeing on the screen is our HEDIS summary report. This is one of our most popular reports in our Evoke 360 application. Now, if you were one of our practices, what our BBC advisory team would do is that we would meet with you monthly. We will look at this report. We will discuss your overall HEDIS and Part D performance. We will look at each measure and help you come up with strategies to increase gap closure and patient compliance. Now, based on the 4 components I mentioned earlier, let's take a look at breast cancer screening, for example. On that very first line there, you can see the measure name. You can see what category they fall into, their weight, how many eligible patients you have, how many are already passing, and how many are still an open gap, meaning they still need to get that test done. Then next to that, you'll see that pass percentage. That is your threshold. Based on that threshold or that pass percentage, it will then determine that start level that you are at. Now, for me, my favorite things about this report is the fact that it shows me on the right how many more patients do I actually need to close that gap in care on so that I can move to the next star level. Okay, you can also see at the top your overall star score and the breakdown of both categories, the HEDIS and the Part D. Right? We're going to go to the next slide and we're going to take a look at exclusions. Now, let's talk a little bit about all of these exclusions. Now, this is going to apply to all of the measures that we're going to talk about today. Now, one thing that to be aware is that some exclusions do apply to multiple measures, and there are some exclusions that are very, very specific for just that measure. So, for example, members who died, who are in hospice, receive palliative care, they're going to be excluded from all the measures. But patients that have an institutional special needs plan or are living in a long-term institution will only be excluded from some measures. Now, there's also an advanced illness and frailty exclusion that have very specific rules that can also apply to some measures. And we've added a slide with all those details for that exclusion on the appendix as well. Now, given the time constraint that we have today, when discussing each measure, I will only focus on those special exclusions that apply to that measure alone. Okay. Now, I have provided them on the slide, but I'm only going to focus on those special exclusions only. All right. So before we get into all the details, we're going to give you one first poll question.
Okay, so on your screens, you are going to see a question come up here. And Yassi, do you want to explain the question and answers?
Yeah, absolutely. Because we could only fit a little bit of words in here, we've given you the abbreviations of these measures. But here is the question. What measures will a 55-year-old female with diet control type 2 diabetes who's not on a diabetic medication qualify for? Breast cancer screening, colorectal cancer screening, and statin use for patients with diabetes is your first one. Middle one, breast cancer, colon cancer, glycemic status, eye exam, kidney health evaluation, and statin use for patients with diabetes. Or the last one, breast cancer screening, colon cancer screening, glycemic status, eye exam, and kidney health. Let's see.
All right, so the answers are rolling in, and we'll give you guys a few seconds to complete this. And of course, your answers are anonymous here. We're going to share the results with you, but that way you can kind of see where you stack among your colleagues and what other folks thought. So it looks like most of the responses, well, we'll give it about 10 more seconds and then we'll go ahead and move on. Okay, doing 5, 4, 3, 2, and 1. I'm going to go ahead and close it out and I will share the results with you all. My goodness, they're still coming in. Here we go. I'm closing it down. All right. Are you able to see the results, Yassi?
I sure can. Very interesting results I see on the screen. I am not going to give you the answer right now. You're going to get the answer throughout the presentation and then pay attention because we're going to do the same question at the end and see if you caught what the right answer actually is. All right.
All right, let's move along.
All right. So buckle up, you guys, because we're going to take you through a very, very fast ride through all the most important things you need to know about each measure. So please don't feel like you need to take lots of notes. Just remember, you'll be getting this deck after the presentation today. We are also even including some bonus slides on there for you. So at that point, it might be a good idea for you to print out this whole deck and use it as your own HEDIS manual for your practice. All right, Lori, let's get this going. We're going to go to the next slide. And the first measure we're going to review is that care of older adults measure. Now, this measure actually has 4 parts to it, where the eligibility and the exclusions are going to be the same, but the documentation requirements are going to be a little different. Now, for these measures, only patients that are 66 and older are the ones that are going to fall into this measure if they have a special needs plan. Now, the requirement for this measure is to do each one of those 4 parts at least once per year. Now, today I'm only going to review 2 parts of it because those are the ones that are going to be weighted by CMS. So the first one that we're reviewing is the medication review. This is probably one of the easiest measures to close since usually most EMRs will automatically contain what the requirements are when you're documenting on a progress note a visit. That is the medications list, the provider signature, and the date of service during any visit during that year, okay? Now, notation that the patient is not on any medication also works in case they're not taking anything. For this measure, it does not have to contain a statement of medications reviewed. The fact that the provider actually signs the progress note confirms that he or she has reviewed the list. Now, I will only mention this part here, but know that this applies to every single measure that we document. All supplemental documents must contain the date of service, at least 2 patient identifiers, which are usually your patient name and date of birth, your provider's name and credentials, and some measures might also require the results and the test type. Now, for the COA measures, you can find forms online like the one you see on this screen that can help you close the gap in care for all 4 of those measures and document them correctly. Now, the best way to close these gaps in care for these particular measures is utilizing the CPT2 codes on the claim. But you can use that supplemental data as long as the documentation is accurate. Now, notice on the form, you also have those CPT2 codes on there, which we've actually highlighted in red for you. But don't worry, we're also providing a CPT2 code cheat sheet on the end at the presentation on the appendix. All right, we're going to go over to our next measure. The second part of this measure that's being weighted is that pain screening. What we're looking for on this one is documentation in the medical record of pain assessment at least once during the measurement year, and of course the date that it was performed. This can be done by having documentation in the HPI or the review system, and it could be positive or negative for pain. An example of this would be no abdominal pain or the patient's having some kind of joint pain. You could also use a standardized pain scale, and this would be as easy as documenting the patient's having 3 out of 10 pain. Okay. Now, an important note on this one is a pain assessment from an acute inpatient setting cannot be used. And if the only thing you have documented is that the patient is on pain management or on a treatment plan or chest pain only, this will not be enough to meet the criteria for pain assessment, right? We're going to move over to our next measure. And this is breast cancer screening. And this is for women 50 to 74 years of age. They'll need to have at least 1 mammogram every 2 years. The NCQA actually gives us an additional 3 months. So if the patient actually had a breast cancer screening done October 1st, 2 years prior to the measurement year, through December 31st of the measurement year, this will actually meet compliance as well. So we get 27 months instead of 24. So for this year, measurement year 2024, if your patients had a breast cancer screening done from October 1st, 2022, all the way through December, that will work. All types of mammograms will work, diagnostic, screening, 3D mammograms, but just know that your MRI, ultrasounds, and biopsies do not count towards these measures. Now, for exclusions, if the member had a bilateral mastectomy, or if they had a gender-affirming chest surgery with a diagnosis of gender dysphoria, and this is kind of new for this measure, they will be excluded from the measure. Okay, now how do we document this? How do we submit that data? If the patient, and we can go ahead and advance to the next slide, I think. If the patient had a mammo done during the measurement year, the claim itself would close it, so you wouldn't need anything else. But if done previously, there is no need for you to go hunting that radiology report, since this can be patient reported. Just make sure that when you're documenting it on the progress note, you're documenting the type of test that was done and the month and the year that it was done. That is really, really important. Type of test, month, and year that it was done. If the patient had a mastectomy, make sure to document the type of surgery that was done and the year that it was done. Now, just know that if the patient had a unilateral mastectomy only, they will still need to have a mammo on the other breast. Okay? Right, we're going to advance to colon cancer screening. And these are members 50 to 75 years of age who will need to have a test to screen for colon cancer. Now notice that NCQA has extended the age range starting at age 45 instead of 50, but this has yet not been adopted by Medicare Stars, although most of the MA plans have already started to include them. This measure, I gotta tell you, is very near and dear to my heart. My brother-in-law actually died at the age of 50 from colon cancer, and he was just diagnosed at the age of 47. So it's very, very important that we get our patients screened for colon cancer. Now, for this measure, and we can go ahead and, yep, we're there. I'm sorry. For this measure, there are different types of tests that can be done, and depending on which test is done will determine the gap, when the gap will reopen. Okay, so I've listed them here on the screen for you. If the patient has an FOBT or a fecal immunochemical test, which is actually a FIT test, those are only good for measurement year. Please be aware that those rectal exams or the FOBTs done in the office will not meet criteria for this measure. The next test is your stool DNA, which we all know as the color guard. This test is good for measurement year and 2 years prior. Then you have your flex sigmoidoscopy and the CT colonography. Those are good for measurement year and 4 years prior. And lastly, you have your colonoscopy, which are good for measurement year and 9 years prior. Now, be really careful in thinking that a colonoscopy is good for 10 years. When you do that, you automatically deduct 2024 minus 10, it puts you at 2014, which actually puts you out of time frame. So please, if you're going to deduct, you have to deduct the 9 years, which would put you at 2015. Okay. Now, special exclusions for this measure: if the patient had colorectal cancer or a total colectomy any time in their history, they will be excluded from this measure. Just know that partial colectomy nor cancer to the small intestine only does not count towards this exclusion. Now, on the next slide, I have actually provided you a little bit more information on the difference between an FOBT, a FIT, and a color guard, which are often very confused because the stool DNA actually used to be called a FIT DNA. Now, the stool DNA, which is the color guard, is good for measurement year and 2 years back, where the other two are only good for the measurement year in which it was done. Right? Now let's look at some supplemental documentation. Of course, if the test is done during the measurement year, the claim will close it. But if done previously, you can use that supplemental data. Now, there are several different things that you can use. If you're using the procedure report itself, the document must indicate the type of test and the date the exam was done. Okay. If you have a colonoscopy report in the chart, it must state that it reached the cecum. If it doesn't say that, it's going to be treated as a flex sigmoidoscopy. And the flex sigmoidoscopy, if that's the report that you have, it must indicate that it reached the sigmoid colon. Again, no need for you to go hunting those procedure reports, since this can also be patient reported. Just make sure that it clearly states the type of test that was done and the year that it was done. For example, you can say colonoscopy 2018. Now, I warn you, stay away from using abbreviations such as just colon 2018 that doesn't fully state the type of test that they had done, or stating colon cancer screening in 2015. Those will not be acceptable. Now, you can use the pathology report and, of course, the lab reports as well, but those must state the type of test and the date of the exam. Again, same thing as if using the procedure reports. Now, before we move over to the next one, Kelly, are there any tips you want to give them about this measures that we just talked about?
Sure. This is really just for all measures that have multi-year look back and can be satisfied by patient reporting. You just want to make sure that you are asking questions on new patient intakes and annual wellness visits that will satisfy these measures, and just make sure that you're capturing everything, all of the necessary information for each measure specifically.
Yeah, that's a great tip. Although you cannot use those as supplemental data, you can use that information to bring it into your progress notes to close those gaps in care, and those can be used as supplemental data. So thank you, Kelly. All right, we're going to move over to our next measure, and that's going to be controlling blood pressure. And now we're talking about members 18 to 85 years of age who had a diagnosis of hypertension. And what we're looking for is that the most recent blood pressure, meaning the last one done in the year, has to be controlled. So below 140 and below 90. Be aware, this is a triple weighted measure. So for exclusions on this patient, on this measure, members with end-stage renal disease, Dialysis, nephrectomy, or kidney transplant will actually be excluded. Now we're going to look at some of that supplemental data. So blood pressures that are reported by the patient are in fact acceptable as long as they're using a digital device at home and you have it recorded in the member's chart. Now, CPT2 codes is the best way to close this gap in care, but just make sure that you've got that documentation in the chart. If there are multiple blood pressures done on the same data service, maybe the patient came in, their blood pressure was a little high, you retook it, make sure that when you're submitting your CPT2 codes, you can actually use the lowest systolic and the lowest diastolic from the two different takes. Okay, I want to give you a really good hint on this one. We're getting towards the end of the year. Anyone in the office can actually call the patient and obtain their blood pressure reading from their digital device. Just make sure that it is actually documented on the EMR. I suggest doing it like a little nurse note. Make sure the provider looks at it, signs off on that, and you can use that as supplemental data or by submitting those CPT2 codes for that date of that blood pressure. All right, we're going to look at the next measure here. And that's going to be your glycemic status assessment for patients with diabetes. New name for this measure. And this is members 18 to 75 years of age that have been diagnosed with either type 1 or type 2 diabetes. And what we're looking for is that their most recent glycemic status, or their A1C, or their glucose management indicator, the GMI, was 9 or below. This is a triple weighted measure for stars as well. Now, be aware that if the patient failed the diabetic medication alone without a diagnosis of diabetes, this has always been a concern. Somebody's on diabetic medications for weight loss, but they don't have diabetes, they will no longer fall into this measure. All right, we're going to look at the next slide. We're going to look at some of those submissions. Now, there are multiple document types that are allowed for supplemental data for this one. I have listed them on the screen for you. Just make sure that besides your two patient identifiers, patient name and date of birth, the date of the test, the type of test, and the results are documented. Now, it is really important that you date that test, even if you're doing it as a point of care testing, if you're testing that A1C in the office, that you're putting the date of that A1C right next to that result, because the date on the progress note does not count. That will not suffice for the date of that exam. Also know that member-reported GMI results can be documented in the medical record and do not need to be collected by the PCP or specialist. Now, the easiest way to close this gap in care is definitely by submitting that CPT2 codes for the results, since usually even the claims from the lab will not contain those CPT2 codes to identify the results and the value. And the value for this one is very important. So Kelly, do you want to add anything to this one?
I'm sure. Just remember that it's the last result of the year that counts towards the final score. It's always a good idea to get your patients with diabetes in earlier in the year. So if their A1C result is not 9 or below, you do have that chance to bring them back in. Just try to avoid waiting until you bringing them back in after the holidays, because their A1Cs may rise a bit.
Yep. All of us and the diabetic patients love all that sugar, right? So we got to try and bring them in early so we get better results. All right. The next measure we're going to talk about is the eye exam for patients with diabetes. Again, same eligibility, 18 to 75. What we're looking for on this one is for the patients to have a retinal eye exam performed during the measurement year. Now, if they actually had a negative dilated retinal eye exam in the previous year, meaning 2023, you can use the 2023 eye exam for 2024 to close that gap in care. For the exclusions, eye enucleation is a special exclusion for this one. Now we're going to go look at that supplemental data. The best thing to have is a note or letter prepared by an eye doctor in the chart. But this can also be patient reported, as long as it is documented that it was done or read by the optometrist or ophthalmologist, the date of the exam, and the results. Now, of course, when done in the measurement year, the results don't really matter for gap closure, but the claim will usually close it. But if it was done in the previous year, it must be clearly documented that the exam was negative for retinopathy. And sometimes I see a statement of diabetes without complication. That statement alone does not meet criteria. Now, there is a CPT2 code that can be used during the current measurement year to indicate that the exam was done in the previous year and it was negative. Just make sure that when you're reporting that CPT2 code, that you have all of the documentation necessary in the chart, whether you have the doctor's specialist report in the chart or you have the correct documentation on the progress notes. Also be aware for special exclusions, blindness is not an exclusion, and retinopathy is retinopathy, regardless of whether it's hypertensive retinopathy or diabetic retinopathy. Okay. Now we're going to get into the next measure for our diabetic patients. This is kidney health evaluations for patients with diabetes, or KED. Again, a fairly new measure, 2 stars. The eligibility for this one, though, notice has been extended to 85 instead of 75. What we need for this one is at least one EGFR and a UACR done at least one per year. Okay, now if we go to the next slide, we're going to look at exclusions on this one. Special exclusion, end-stage renal disease or dialysis. Now, usually the claim for this one will close the gap because it has to be done within the measurement year. But if necessary, because the lab didn't submit a claim or something, you can use the lab reports as long as it has those two patient identifiers, the date of the test, and the type of test that was done. Now, the results don't really matter on this one. The fact that it was done will actually close the gap in care. Kelly, any tips for them on this one?
Sure. So we've already mentioned bringing your patients in, the patients with diabetes in earlier in the year. Just make sure that you're ordering the EGFR and the UACR with the first A1C ordered in the year. That way it just doesn't get missed.
Great tip. I like that. Thank you, Kelly. All right, we're going to move over to our next measure, the osteoporosis management in women who had a fracture, or OMW. So these are women 67 to 85 who suffered a fracture between July 1st and June 30th. They will then qualify for this measure. Now, what we're looking for on this one is that the patient either gets a bone density mineral test done or a prescription to treat osteoporosis within 6 months of that fracture. Now, for the exclusions, notice that if the patient actually had a bone density scan 24 months prior to that episode date, or osteoporosis therapy or dispensed medication within 12 months prior to that episode date, they will be excluded as well. Now, notice that this measure goes from July 1st through June 30th. The reason why this measure doesn't go January to December is because if the patient actually had a fracture after July 1st, since you have 6 months to do that bone density scan, that will actually fall into the next measurement year. And because we measure everything January to December, we want to make sure that we know that this measure closes out on June 30th, and anybody that has a fracture 2024, July 1st, through December 31st of 2024 will actually affect your scores for 2025. Also keep in mind that if patients only have a fracture to the finger, toes, face, or skull, they will not be included in this measure. On this next slide, I have actually provided you a list of the medications that will close the gap, as well as the documentation requirements on this document. So, Kelly, is there anything you want to mention about the OMW?
Sure. Patient report is not allowed for this measure, but it's still a good idea to ask for the BMD test on patient questionnaires. That way, if you need to obtain the report in future, for the future, that you'll be able to go back and find those reports.
Yes, thank you, Kelly. All right, so we're going to look at follow-up after ED visit or FMC. These are members who are 18 years of age and older with multiple high-risk chronic conditions. That's who will qualify for this measure. Now, what we're looking for is for the patient to have a follow-up service within 7 days. Now, if you count the ED visit, that will give you an 8th day. And this measure runs January 1st through December 24th. Kind of cuts off early because you have those 7 days to close that gap in care. And the member qualify for this measure when they are reported to have 2 or more of the conditions listed here. Now, each bullet represents a condition. So if the patient actually has COPD and asthma, that only counts as 1 because they're part of that same bullet there. Okay, now we're going to look on the next slide on what our special exclusions are for this one. If the patient actually gets admitted, whether it's from the ED visit or within 7 days of that ED visit, they will actually be excluded because they will need a follow-up office visit after the inpatient discharge. Now, also know that if the patient has a second ED visit within those 7 days, that original ED visit kind of gets wiped out and you don't need a follow-up because the second one takes precedence, and you are going to need that follow-up within those 7 days. Again, counting the ED visit will give you an 8th day. Now, notice there are many types of visits that will qualify as listed on this slide here. They will all qualify, and if submitted on a claim, if their charge is submitted on a claim, that will close the gap in care. But there are other documents that you can utilize. So if we want to go ahead and look at the next slide, there are documentation that will allow you to close this gap in care as supplemental data. Just make sure that document is dated within 7 days of that ED visit. The documentation must, of course, include the patient's name and all of that, but it must include also the name and credentials of the person completing this follow-up, as well as the clinical decision-making orders or verbal assessment of a condition, changes in treatment, counseling, new orders, or patient education. Just documenting that you know that the patient was in the emergency room and that the patient doesn't want to come in for a follow-up, that's not enough to close that gap, okay? Documentation can also be a telephone visit containing all of the mentioned requirements, but it can also be done with the patient's guardian or spouse. You do not necessarily have to speak to the patient. Now, be aware that every ED visit will represent a new event, and a new office visit will have to be done unless, of course, it's done within those 7 days, if you get a new ED visit within 7 days. Now, a little hint on this one. The telephone visit does not need to be done by the provider. It can be done by anyone the provider delegates this task to. All right, we're going to move on to the next measure. That's our plan all cost readmission. And I'm not going to talk a lot about this one. It's probably one of my least favorite measures. This measure includes members that are 18 and older that had an unplanned acute readmission for any diagnosis within 30 days of a previous inpatient or observation stay. This is a triple weighted measure for 2024. And I will not spend much time on this one, but Kelly, do you want to add anything on this one really quickly?
Sure. I just suggest that you monitor and frequently engage your patients who have comorbidities and those who have rising risks for acute events. You can utilize your case management programs, and if you don't have internal programs, make a referral to the payer's case management program. And I think that the activities that you undertake with the transition of care measures are also going to help you with this measure, and that's what we're going to talk about next.
Yes, so the next measure we're going to talk is those transition of care measures. And this measure actually has kind of 4 parts to it. The first part is notification of inpatient admission, and all we're looking for is documentation in the medical record of that patient admission from the day of admission to 2 days after, so 3 days total. The second part is a receipt of discharge information. Really simple. Do I have that discharge summary within the date of discharge to 2 days of discharge? And the third one, patient engagement after inpatient discharge. What we need on this one is documentation of patient engagement within 30 days of discharge. And it could be outpatient visit, any visit, virtual check-in. Just please note that the patient engagement that occurs on the date of discharge does not count for this one. It has to be the date after discharge. And lastly, the fourth part is that medication reconciliation post-discharge. What we're looking for on this one is documentation in the medical record of reconciliation on the date of discharge through 30 days after. So for this one, you do get those 31 days. Review of documentation of the discharge medication reconciled with the most recent medication list in the outpatient medical record. And this can be done by anybody like the prescribing practitioner, the clinical pharmacist, a physician assistant, or even a registered nurse. And this can even be done in the absence of the patient. We like to call this a desktop review. That means you get the discharge medications and you review them against what's in the medical record, and you decide, the provider decides whether or not there needs to be a change of medication or not, and you can document that and submit to close that gap in care. Now, for this one, it is best though that the documentation states that the medications were in fact reconciled. Now, on this next slide, you were good, Lori. On this next slide, we can see that just like with the FMC, this measure is based on discharge events, not patients. So if the patient is admitted or transferred into another inpatient facility within 30 days, the reconciliation is based on the last discharge date. Now, depending on the type of visit that is billed, there might need to be a CPT-2 code that includes that medication reconciliation post-discharge, so that that portion is also closed. And I've given you all of the details on this one there as well. Kelly, any suggestions on this one?
Sure. Make sure that you create procedures to ensure everything is documented appropriately. Ensure you have personnel assigned for receiving notifications, obtaining and reviewing discharge records, and doing patient outreach. And if you have a patient scheduled and they cancel or don't show, keep in mind that you can still close the medication reconciliation by ensuring the review was completed and it was by an appropriate provider, and then documented in the EHR.
Awesome, thank you. All right, we're almost there. We've got the next measure. It's going to be your medication measures. And this first one is the statin therapy for patients with cardiovascular disease. This one is very similar to the statin used for persons with diabetes measure, which we'll look at next. And they can easily be confused. Now, the SPC is actually a HEDIS and CQA measure, where the SUPD is actually a PQA Part D measure. Now, for this measure, males 21 to 75 and females 40 to 75 who were identified as having a clinical atherosclerotic cardiovascular disease will need to have at least one moderate to high intensity statin filled during the measurement year. Again, this requires one pill, one fill to satisfy this measure. Members are identified either by having an event or having a diagnosis. And there are special exclusions listed on this slide for you. But I got to tell you, one of the things that I hear all the time is, hey, if the patient was intolerant to statin, can they be excluded? Now, the short answer to this is make sure that you check with your payer. But usually, unless the patient has one of these diagnoses, they will not be excluded. But again, remember, this measure only needs one pill, one fill to satisfy it. If they do a second fill, though, they will end up being added to the medication adherence for statin measures, which we'll review in a few slides. Okay, and we're going to go over to the next measure, and that's going to be statin use in persons with diabetes, or that SUPD. For this measure, members 40 to 75 with diabetes who received at least 2 diabetic medications pill will qualify for this measure. Let me say that again. Those who received at least 2 diabetic medications pill will qualify for this measure. So what we're looking for is to have at least one dispensed statin medication of any intensity during the measurement year. Again, for this measure, one pill, one fill will satisfy. And usually for this measure and the previous measure, submissions will be claims by pharmacy only. Now, although certain health plans do allow supplemental documentation for those exclusions, so just make sure that you check with your health plan as to what their guidelines are. Now, again, if the patient gets a second fill of this medication, that will fall into the medication adherence measure. All right. we have finally reached the last measure we were going to look at today. And this is medication adherence. Again, a Part D measure. This is also triple weighted, and there are 3 triple weighted measures for this particular measure, and that is medication adherence for diabetes medication, hypertension medication, and statin medications. Now, what we're looking for is to make sure that the patient picks up their medication on time to cover at least 80% of the time that they have to be on this medication. We call this PDC days. Patients will be added to the denominator when they fill their second fill of the medication. Now, those PDC days, though, go back to the very first fill they did. And it's a bit complex. We will not get into all of that. But basically, if you look at the day that they filled their first prescription through December 31st, and you count how many days there is, and you multiply that by 20%, that kind of lets you know how many days they could miss and still be compliant. Okay. Now, if I've included a little chart for you in the appendix that can help you understand this part. But the most important thing about this measure is to internally come up with a workflow to help patients stay compliant. And there are several things that you can do. First, make sure that you get your patients on 90 to 100 days prescription. This allows for less days to be missed. Try not to give them any samples after you've already started them on that medication. And please don't tell the patient to split the pills if the dosage is being cut in half. Rewrite a new prescription with the correct dosage so that the fills can be counted accurately. All right, that's it. We have reached the end of our presentation. I will pass it over to Garrett. But before I do, let's do that last poll question.
Okay, yes, we're gonna do the follow-up poll question and see how the presentation did for you. So I'm gonna launch that now. You'll see it on your screen, and it is the same question as before.
Yep.
And yes, did you want to read the questions and answers again?
Sure. So one measures with a 55-year-old female with diabetes control type 2 diabetes who is not on a diabetic medication will qualify for. And again, same answers: breast cancer screening, colon cancer screening, statin use for persons with diabetes, breast cancer, colorectal, A1C, eye exam, KED, statin use, or the last one, breast cancer screening, colon cancer screening, A1C, eye exam, and KED. And we are fighting for 2 and 3 there. And so let's see how we do. We got about 50% of people voting. I kind of gave you the trick when I was really reading through that one measure. So let's see if we got it. Okay, you let me know when.
Okay, looks like most of the answers have come in. We'll give it about another 10 seconds. And all right, we're going to go ahead and close it down here and share the results.
Awesome. Well, I am excited to see that there was actually an increase in the correct answer. And the correct answer is actually the third one: breast cancer screening, colorectal cancer, A1C, IED, and KED. The reason why they wouldn't fall in the SUPD is because they have not failed their diabetic medication yet. They are diet controlled. And for SUPD, you fall in that measure when you pick up your second fill of that diabetes medication. Originally, we had about 40% on that answer, so I'm excited to see another 10% there increase. So good job, everyone. Thank you, Garrett.
Okay, so we do have a little bit of time for some Q&A here, and I know there's a lot of questions, a big audience today, so don't worry if we don't get your question answered. Don't worry, someone's going to reach out to you via email to answer your question. So we'll get to as many as we can. We have a couple minutes, so in no particular order. First question is this: what if we don't have the capacity to work all these measures?
Kelly, I'll let you answer that one.
So I'll start out, and then Yasti, go ahead and add to this. But if you don't have the capacity, one of the things that I would definitely, suggest first is focusing on those heavier weighted measures. Now, if you're in a provider's office, just keep in mind that it's the Medicare Advantage contracted measures that you're going to want to focus on. But those heavier weighted measures are definitely going to be the ones that I personally would focus on for the contract. Now, also, you can use a couple of resources. Payers have resources that are available to you, so you can help ask them to see if they can help you with any of these measures. And also, you can work with an organization like ours. So I had mentioned earlier that we have a team that works with providers every day to help them be successful with these measures. So if you are struggling, reach out to us and let us know how we can help.
Absolutely. And one thing that I want to add is just to remember this is providing quality of care to your members, right? So if you understand what these measures require, it's really easy to just document what needs to be documented, order the test on their patients. But I know the biggest gap is getting the patients to do what they're supposed to do, right? The providers do it. Everybody in the office is doing what they're supposed to, but the patients are not. And it's really hand holding and educating those patients why these things are important. It's not that you really want to just be a pain. It's the fact that you are providing quality of care for them, and it is important for their health to be able to get this test, and these measures completed.
Yeah.
Right?
Okay, next question, and we are running out of time. I think this might be, unfortunately, the last question that we're able to take here. For EED, you mentioned that there are other things that can be documented that show negative retinopathy. What is that?
Sure. So it can say dilated retinal or fundus exam, and does state that it was a dilated eye exam. For the results, sometimes the doctors will document something like vessels normal or AV ratios 2 out of 3. Maybe they'll document fundus normal or versus vessels normal. All of those documentation will actually satisfy for a negative retinopathy exam.
Okay, well, that was a quick answer. We might have time for one more quick answer here. Um, we are struggling with the FMC measure because we are not getting timely
Mm.
notifications from the hospitals. What can you suggest that would help us?
Kelly?
So this has definitely been a struggle for our. So this measure came out a couple of years ago. It's been a struggle for our practices that we work with for quite a while. One of the things that you can do is look to see if you can work with a HIE in your area. See if you can establish a connection with them. Sometimes they'll even have alerts set up through the HIE to just alert you when there has been an acute event. So that would be my suggestion. Do you have anything to add, Yasti?
I do, yeah. A lot of times, what we can do is learn from our history, right? Look at those patients that qualified for this measure in previous year and make sure that you're educating these patients to not just call after the ED visit, but call you before they go to the ED to the hospital, right? Now, I know sometimes they just have to go to the hospital and there's no time to call you, but just kind of educate them that it's really, really important that they come to see you or call you after that ED visit. So to me, getting those reports, looking at those patients, educating them, and even adding little alerts in your EMRs. Sometimes some of the EMRs will allow you to put a little pop-up notice, hey, this patient needs to call us after ED visits. And that way, when they come in for an appointment, the MAs, the providers can definitely, again, remind those patients, remind the family members, hey, if they end up in the ED, we really need to see them within those 7 days.
Very good. Very good. Well, I hate to do this because there's so many wonderful questions running in here, but that is all the time that we have because we're right up on the hour. But if you have a question that didn't get answered, or you have one right now, go ahead and put it in because someone's going to reach out to you via email to answer that question. But as we close out, first of all, Yasti Kelly, wanted to thank you for a fantastic presentation. This was wonderful and obviously so much here. And we're going to be sending out the recording, a link to the slides where you can download. There's an appendix to the slides that has a bunch of information. So please look forward to that. And then as we close out, I wanted to encourage you all to head over to vbcexhibithall.com and check out the Data Link virtual booth that they have there. There's a lot of really cool materials and resources there. You can learn about what they're doing in the space, get in touch with them, and really educate yourself on them if they can be of any help. And I'm happy to facilitate an introduction as well if you wanted to reach out to me. And then finally, if you would like to reach directly out to our team here, our DataLink team, you can contact them here at info@datalinksoftware.com. Or again, reach out to me. I'm happy to facilitate an introduction. But thank you again so much for spending your afternoon with us. Yasti, Kelly, thank you so much. And we will see you on the next one.
Thank
So
you,
good
Cheers.
Gary.
Good
afternoon,
afternoon.
folks.
Bye
Bye-bye.
bye.
Bye-bye.